Okay, North Carolina. It's fun to be here. 117 years. That is a great achievement. 17 is my birthday. So that relates. I'm getting a lot of signs here too. My birthday is August 17th. My room number was 87. Tried my first Bojangle in North Carolina. And a lot of good memories here. But I want to thank Southern Medical Association, Dr. Carter. Thank you very much for inviting me to speak here. We met last summer. And then he said, like, oh, I want you to speak in October. I'm like, oh, in 3 months? He's like, no, in 15 months. I'm like, wow. And, you know, at that time, it felt like it's a long time ago. And I can't believe that time is already here. And thank you, Randy, and your team has been great for supporting me during this process. Okay, so a lot of times, you know, people want to know more about me. My friends call me CIA, not because I'm smart to be an intelligence agency. I was born in Canada. I grew up in India, and now I'm in America. That makes me Canadian Indian American CIA. I get in Q&As, I always get a question. So there's one question I'd like to answer now, like which is the most frequently asked question. Your colleague cardiologist, Dr. Patel, is not my father. On a serious note, you know, any presentation I do, you know, this is a jam-packed 3-day weekend for you with fun, learning, opportunities, networking. From this presentation, I just want you to take 3 things. It could be any 3 things. Something might relate to primary care, something might relate to a specialist, but 3 things. And I want whatever 3 things you learned from this presentation, go and talk to your colleagues about it. And that's how we want to educate and spread the message that we learned here, and try to practice that. Okay. Randy, oh. Okay. So every presentation I start with, I'm grateful for. I'm grateful for today speaking in front of you, sharing the knowledge that I have in geriatrics. I'm very grateful that I don't have to worry about the next meal for my kids. There's been a lot of places in the world that happens. Our senior itself in our own country has a lot of food insecurity. I'm grateful that my kids have a house, what's going on in the world, you know, not tucking in your kids safely at night. It's just sad. And third thing, which we take little things for granted. I've been out since Tuesday and I'm planning to do my laundry tomorrow. And what if that washing machine doesn't turn on, right? So every day that turns on when I need it, my car turns on every morning when I have to leave, my washing machine turns on. These are the little things that we never appreciate until that thing stops working, right? Think about it now, like you go home and all of a sudden your microwave doesn't work. Right? Like it's little things that you always take in life as granted because it always works, right? So I want you to think about in this 2 days, 3 days, when you're driving home or taking your flight back, think about one thing that you are grateful for and thank them. This is the mantra I follow every day. I'll care for my patient as I'll care for my grandmother. She has played an amazing role in my life. And in my book, you'll get to know her a little more. And she used to always tell me that, you know, when I used to whine about sometimes difficult patients, and she used to always tell me, I have a secret sauce, a formula for that. I'm like, okay, grandma. Grandma always have secret recipes, right? And she told me, when you have a difficult patient and you don't know, or it's very complicated, you don't know the next step, think about if that patient was your grandmother, what you will do. And you will find the answer. And you know what? I do. As a doctor, as an administrator, any decision I make, I always think how that will affect clinically to my patient, or making an administrative decision as a chief medical officer, how that will affect if that patient was my grandmother, and I walk out with an answer. So when you are thinking about your difficult challenges in medicine, those are the times. Think about, that could be any of your loved ones. Think about, would have done the same thing if that patient was your loved one? And if the answer is yes, don't worry about anything else when you're practicing medicine. Okay, so are we prepared for the silver tsunami? The answer is no, right? So when you're thinking about the aging population, in 1900, only 4%. Sounds low, also 3.1 million. By 2018, it was 52.4 million, where 65 and above. Now we are thinking of 83 million by 50, right? 10,000 people turn 65 every day. So when we are talking about right now about older adults care and how we are doing, we are still in the 53 million range. Think about the shortage of beds that might happen in a skilled nursing facilities or hospital beds. What are the innovative approach we might have to take in future to care for the patient? And one thing that we always forget is the caregiver, right? Right now, it's 1-to-7 ratio of caregiver. When they say that, it's indirectly, it could be, the son, daughter, other family member coming and helping. What's happening now, the migrations are happening out. People can work more remote. So a lot of times, people are moving out of state. But parents are still rooted in North Carolina, that they don't want to move to California or some different state. So what we are looking on, and in future will happen, that caregiver ratio will decrease. And how many times you have seen a burnout caregiver? The opposite. So if that ratio decreased, think about what proactive approach we might need to take. So I'll start you with the story. I was a young geriatrician, signed up as my job as a medical director in 2016. And I was like, have you heard about, anybody have heard about a PACE program? It's program for all-inclusive care for the elderly. Actually, North Carolina is one of the growing market in PACE, and they are doing some great work in PACE. So it's a value-based care. So I signed up as a medical director, excited. My first job, I get a phone call from my CEO of the health system. And that, oh, my CEO wants to talk to me. And it's like, oh, Patel, let's meet for lunch. I'm like, wow. I was like calling my wife, my friends. I'm like, I'm having lunch with my CEO. And I go and sit there, and he's like, how are you? I'm like, good. I'm planning to shut down the PACE program in New Jersey. I'm like, oh. I'm like, I moved from Virginia Beach for this job. Like, I have family in Jersey too. And he's like, yeah, it's not doing good. We are losing $3 million and we need to shut this program. But I'm like, I moved. He's like, oh, don't worry. You're a smart geriatrician. We need you for post-acute care, population health, and all the things. I'm like, PACE is my passion. And I'm like, would you shut down tomorrow? He's like, no, like maybe in 6 months. I'm like, that's it. I need 6 months to turn this place around. And that time he asked me 3 questions. Can you turn this around? I said, yes. How you will do it? I have no clue. How much time you need? I'm like, that's already given that you told me 6 months. So on my drive home, this was my question in my mind. Now what? I'm like, I have call my wife on my drive home, and she's like, why do you have to promise all the 6 months thing? And I'm like, well, they wanted to shut it down and I have 6 months. So what we will do, and this is where sometimes when you commute for work and you drive along and coffee and music, that's what helps. So that's what we started thinking. I'll come back to that story. So started working at a PACE program, and I walked into one of my first weekend patients. And I see a 72-year-old patient, walks in with multiple falls, confusion, not safe at home. Daughter was very concerned. I saw tears in her eyes. She told me, looked at me, Dr. Patel, my father has been falling, he's confused, he's not at his baseline. And I have to put him in a nursing home. And she just broke down in front of her father. Her father started crying. Not because daughter wanted to put him in a nursing home, but that day he realized that he's a burden to the daughter. And that was something that he was, Dr. Patel, just give me a minute. And these are the things that, we see in the clinic. And I'm like, okay. So then I looked on my right side, because every patient that I see, my team knows, Dr. Patel won't see a patient if there is not, the home medications are not brought in the clinic. They all know, right? So what happens? And my team knows they need to bring 2 bags of medicine. 1 bag of medicine is what they are taking in 1 bag. The second bag of medication, what they are not taking, but they still have it. Right? Bring that bag in too. So you come in with 2 bags of medication. And this patient was on 36 medications. 36, right? And think about it. You all know not all medications are once a day, right? Some are BID, TID. 36, 26 were prescribed medication by 5 different doctors and 10 over-the-counter medication. 5 different doctors. We know in healthcare, as much as we brag about healthcare, the EHR doesn't talk to each other all the time. So what the cardiologist started, nephrologist won't know, nephrologist started, pulmonologist won't know. What they all 3 started, primary care won't know. Okay, so on my drive, I'm thinking what I need to do. Patient normally goes from hospital to ER. When my geriatric patient usually hit the ER, 70% of the time they get admitted. And the reason is not ER's fault. It's just their sick appearing patient to ER that they don't feel comfortable discharging the patient home. To me, Miss Smith looks better than even yesterday, even if she was sitting in ER a lot of times. But ER will go ahead and admit. And think about this transition that happened from home to ER to the hospital floor, right? From their passively skilled nursing facility and home. In this 5 transition, how much error you think in that med list happens? 100%. If you have 5 or more transitions for any patients that's happening, it's 100% chances of error in medvac. So, came up with a formula, which I call the 3 Ps. And that same CEO now is calling 4 Ps. He added the Patel's formula. And I'm like, okay, so these are the things I need to focus on. So what prevention is, right? So in prevention, I'm thinking about what I can do to prevent a patient going to the hospital, ER, because that's how they get into the ER. Second thing, host form, which is in New Jersey, we use it more. It's called the physician order of life-sustaining treatment. So it's like advanced directive for the medical. So be more focused on that. And then third is polypharmacy, and that's what I'll focus on more. Okay. Last year in China, there was an air crash where 123 people died, and it was national. If you missed that, you might have heard about Air Malaysia that missed a few years ago, was a national, right? So any event with plane crashes or plane goes missing, it's always on national news. So why, when 290 people die every single day, it doesn't make national news? 290 people die every day. That's 1 in every 5 minutes. By the time I'm done with my talk, 12 people will die from adverse drug event. And I have never seen that in news. If adverse drug event was a disease, it's the 4th leading cause of death. Right? So what is adverse drug event? Mostly you get that either any side effect or medications errors. Compared to younger adults, older adults are twice likely to visit ER and 7 times more likely to be hospitalized because of adverse drug event. That's your answer for proactive medicine, right? That's the theme. This is something that's preventable. 2/3 of adverse drug events that happens are preventable. But guess what? 101.3 million ER visit, 350 hospital admission, and 160,000 deaths a year that happens. These are documented. And we know how good we are in documentation, right? How good we are in kind of reporting certain things. So think about, do you think these numbers are accurate? These are the ones that we know. How many times an adverse drug event related fall might be happening home, but the patient will never tell you? You know why? Because they feel like they'll send my daughter and son will put me in a nursing home. That's why they don't tell about the fall. So to be a good geriatrician, you need to be a good detective. Don't ask the patient, did you fall at home? Ask them, how many times did you fall in the last 6 months? Oh, once. Okay. And if they say no, that's great. But that's the same thing. I used to ask my patient, do you take your medication? They're like, yes. Have any patient said I don't take my medication? So what I started asking them, if they were on inhalers, I'll show them an inhaler and be like, how many inhalers do you have at home? Oh, I have 5. Okay, so you have to take once a day, these inhalers. If you have 5 at home, you're not taking it regularly. Right? So that's how you need to kind of approach these patients with that. So polypharmacy, a wide definition. General rule of thumb, somebody more than 5 in medication is polypharmacy. Realistically, when I see somebody with 7 medication, I'm like, oh, thank God, it's not 17. Right? Numbers doesn't matter. What it does to that matters. Because here is the thing. If somebody's done 2 medication, 13% chances of adverse drug event, 5 medication, 58% chances of adverse drug event, and 7+ is 82. So to me, that 82% matters. That if I know somebody walking in with 7 medications, 7+, 82% chances of adverse drug event, that's what matters to me. I need to work on that before a fall, a confusion, or something like that happens on the patient. Right? Does this picture look familiar? This is the reality. That one time I walk into the office and normally I say they need to bring 2 bags. And I always think that's those brown bags. Patient walked in with this. And my team is like, this time they didn't have a bag. I'm like, okay, what they brought the medication in? And she's like, boxes. And I'm like, oh, this is two patients. This is only from 2 patients home. And that's the beauty about sometimes doing that good old primary care and doing home visits. This is where you find what goes on at home. But what bothers, right? What happens? We have a mindset that we are always taught about prescribing, right? We need to change that mindset to de-prescribe, right? Thank you. And the reason I'm saying it, we want to practice evidence-based medicine because that was taught to us in evidence-based medicine. Oh, if somebody has systolic heart failure, EF less than this, ACE and ARBs and beta blocker and Lasix and digoxin and all this thing, right? This is realistic-based medicine. And this is what we need to be. It's okay. They don't have to. And when they do all these studies, those are the healthy 65 years old with 2 medications. They all make the study. Do you think my PACE patient and a normal geriatric patient who is on 10 medications with 5 chronic diseases makes the cut in those studies? No. Every day, one thing, I always teach my residents and students 2 things. Evidence-based medicine is to pass your exams. Realistic-based medicine is to get the best quality out of patient, what matters to them. Patients are not taking a lot of time medication because they are just on 12 medicine and doc, I don't want to take anything. So what matters to you, Mr. Smith? Well, I want to just go to church every Sunday for the rest of my life. That's important to me. You know what? Don't worry about your ACE and the ARBs and this. Make sure you're on your Lasix so you breathe better. Right? So how I can bring that 12 medication to 4 medications sometimes? Because if you want to practice evidence-based medicine, great, but they're not taking any. With realistic-based medicine, they will at least pick the 4 medications. Mr. Smith, if you want to go to church every Sunday, at least I want you to focus on this. One time when I was a geriatric fellow, not geriatric fellow, yeah, that time, this old fancy medications like Eliquis and Xarelto wasn't there. So when for knee replacement, that's what they used to do, like Coumadins for days, right? So I have a patient coming in on Coumadin, and I always go reverse. Look at the med list, and then look at what disease are attached to that medication, and then go and follow the rest of the history with that patient. So what happened that day is I'm like, oh, why you are on this blood thinner? I don't know. Call the daughter, why you on blood thinner? I don't know. I'm like, did doctor told you like he had irregular heartbeat or you had a clot? Like, no. And the daughter told me, no, 5 years ago, mom was started on a knee, after knee replacement was started on this blood thinner medication. And I'm like, whoa, 5 years. You're good. You'll never have a DVT now from that knee replacement. But I'm glad you didn't bleed. She's like, oh, but mom was not regular with her medication. And I'm thinking in my mind, thank God that she was not regular taking her medication. Nobody was measuring the INRs for that medication. Right? So I'm not here to tell you how to de-prescribe or what medication to de-prescribe. Everybody in this room knows long-term PPI. Is it good? No, they're still on it. Right? So I'm not here. I want you to go out and think about a few things, right? Connect the whys with the medication. Right? That's one. 2, PPIs, you know. If everybody in this room de-prescribed 2 PPIs from 2 patients, next week we'll have 600 people of PPIs. Right? Dual antiplatelets. Why people are on dual antiplatelet like 4 years after their heart attack? Does it happen? It does. Why are they on dual antiplatelets after 8 months after stroke? They need to stop smoking to prevent a re-stroke. Do they really need dual antiplatelets, right? Why people are on statin when they're 90 years old? Right? But it happens. So it's us there. You know, a lot of things we blame on other people with administrator makes me see 25 patients. I don't have time. You know, my schedule is full. We don't have nobody else time. Somehow, average use of your phone is 8 hours a day. Right? So there is some time that we need to kind of figure it out, but de-prescribing should be your priority. So I want you all to walk and commit that at least you will de-prescribe on 2 patients now. That's what I'm asking for. And if you do that, my talk coming here was worth. So what changes? And a lot of times we have to explain the patients too, right? Our patient will be like, no, doc, I'm taking this medication for the past 40 years and I'm not changing. Right? It's okay. Explain that. But you know what, Ms. Smith? Your body changes. The water in your body changes. The fat amount of your body in the changes. The kidney level changes, right? Explain them. So that means now you may not need 40 milligrams. The 20 milligrams of the medication might do the same job. And a lot of time you won't get resistance. So those are the things that you have to kind of explain them, that as you age, your body changes, right? So here is, I want you to kind of see which category of prescribers you are. Okay, and I'll go to all the 4 categories one by one and see what is what. And I want you to at least, if you are a preference-based medicine prescriber, I want you to at least move to a personalized after this talk. And I'll explain you what is that, right? If you're doing personalized-based prescribing, I want you to move to precision-based medicine, right? So what is preference-based medicine? Traditional trial and error. The best example of preference-based medicine is SSRI, right? You start somebody with depression. Let's start them on this. Titrate it in 6 weeks. Well, it doesn't work. Oh, some medications are not meant for some people. let's take them off, try another SSRI, and see if that works, right? That is really your preference-based medicine. That some people might pick this beta blocker over this, some people might pick this ACE over this, right? So that is all what we practice is preference-based medicine. And then what we do in preference-based medicine, if the EHR pops up that one alert that A and B interacts with each other, and we say, okay, we know, right? But what about C, D, E, F, G medication? What do we do there? Right? So these are the things that we normally do one-on-one interaction. Then what I want you to do moving forward is the brown bag defense in that, right? Educate your patients. So, you know, AMA was just saying about education, how much proud they take in education. SMA, education, right? These are the education needs to be done to the patient and empower them that if they're going to their cardiologist, nephrologist, any of the ologists, ask them, that empower them that these are the questions you need to ask your doctor. Why I'm taking this medication? Because just when doctors start explaining all those things to the patient, the doctor's bell will go off and be like, you don't need this one. Right? So ask your patient, empower them why they're taking the medication. If they're starting, what are the side effects of these medications that I have? If they're changing the medication, what is the reason for the dose change? Is it because my blood pressure is high? Is it low? What is the reason to change? Because sometimes when I say, oh, I'm changing your blood pressure medication or adding a blood pressure medication to your regimen because your blood pressure is not controlled, then you know what they'll say? Actually, I didn't take my medication. Oh, I don't need to add it. Actually, you're on 3 blood pressure medication. I'll take even 1 off of that. Just start with 2. But how many times you think that happens in the hospital, that we are admitting a patient in the hospital, we assume that that list was put in the ER is correct, with those 3 blood pressure medications and everything, and we pick yes, yes, yes to all. And what happens? The nurse gives you a call, so-and-so's blood pressure is 80 or 40. Yeah, because they were not taking any of them at home, and we started them on. Let's move them to ICU. Let's give them IV fluid. Right? So think about this whole theme of this conference, proactive versus reactive, and how many examples of reactive care has been happening under our watch. At least we need to be pride about that, you know what, after this conference, I won't practice reactive medicine and I'll practice proactive. Have you seen anybody die from a blood pressure of 155, 160? It's okay to do, you know, start 1 medication in the hospital instead of 3. If it's at 160, 70, the nurses are good. They'll call you. Even at 2 o'clock at night, they will call you, right? Okay, add this another one. See how they are doing. But they're not taking at home. There are a lot of those medications. And then you kind of look into what's the end date for medication. And this is for all the residents and med students in the room. Get into a habit for end date of a medication. Antibiotic, 14 days, end date is October 17. Every medication that you discharge a patient needs to have an end date with the date on it, right? So now the question comes in, because your PPIs get started just because of there was no end date in that. And then it just continued to remain on the list. We don't want to be that doctor who started on warfarin and never. I never blame the doctor for that warfarin case, that 5 years to other doctor, but I'm like, why the first doctor didn't prescribe and wrote it down somewhere that this needs to be discontinued in 14 or 21 days? Now the question about diabetes, blood pressure, all this medication. We know there may not be an end date for it. So keep it in your mind that do I have an opportunity to de-prescribe this medication? Right? So for my patients are very hard. They sometimes don't bring their medications in. So when I started working at that program, and one of the polypharmacy drives, I started doing it. Look, I need to clean this up. So I got a pharmacist. My pharmacist got students, med students. I'm like, hey, if you come there, we'll go for happy hours after this. They all were there. I had like 14 medical students lined up. So everything, we set it up, and I'm like, patient needs to bring the medication. None of them were bringing it in. So in South Jersey, we have Wawa, it's a gas station, right? People love it. I'm like, everybody gets a $10 Wawa gift card if you bring 2 bags of medication. One is you taking it, the other bag, the things that you're not taking it. Guess what? We were discarding boxes and boxes of medication every day. We cleaned up the whole list. Took 2 months, but we did that. So, and I will kind of walk you through what happened afterwards, right? So from preference-based to personalized. This is what I call personalized, right? With one-on-one interaction of drug, those days are gone. Those days should be, technology is a lot better that we need to embrace, that now you need to kind of look into not just A and B interacting, look into A, B, C, D, E, F. And when they interact together, what happens there? That's what we need to focus on in personalized, right? What happened? This is what I use. I have a technology that we use. I'm the chief medical officer for that. But here what we do, that it gives me, so out of my, let's say if you have 5,000 patients in your clinic, or let's say 3,000 patients, do you know which 300 patients are the most sickest one? Like, can you pull up like that? No, it's very hard. You don't know how to risk stratify that, right? Because we are looking at technology. And there's no perfect technology that I'm always saying I recommend this over this, but something that helps me. So I use my technology that kind of gives me a number from 0 to 50. Anybody 30 and above, you're very high risk for adverse drug effects. So that's what I focus on. So if I have 500 participants who are all sick, but who are the sickest? So I look at the 25 patients who are the sickest, kind of start working. And then they will tell me that why they are more sick and why they have better chances for adverse drug effects. So I look at anticholinergic burden score, right? Anticholinergic side effects, right? Constipation, dryness of mouth, eyes kind of feel dry. So what we end up doing? Prescribing Miralax, Senna, right? All the medication for constipation. A lot of time we need to de-prescribe the medication that is causing the constipation, which is your anticholinergic burden score, right? So something to look kind of up, that which medications have the highest anticholinergic burden effect. A lot of them will show up, but why don't you think on the first 5 medications, right? So that's how you think. If instead of anticholinergic burden score, if the sedative burden score is high, then what I'll do, I'll start focusing on medications like the opioids, the benzos, that brings the, so is there an opportunity that I can de-prescribe those medications? So that's personalized. But I'm like, you know what? It's very easy to blame a patient on pain medication, right? We always have that bias. Oh, needs one or more pain medication. Have you seen anybody coming and saying you, oh, I lost my metformin prescription? It's always the opioids, right? Always the benzos, right? And we judge them in one. We have that bias, believe it or not, right? As much as we say, but those are the things, actually, when I started looking at it, some were able to do well when I was prescribing, some were not. And I'm like, there's some missing piece in the puzzle now. Like, what else is missing? And that's what I'm like, you know what? I'm so proud of personalized based medicine, but then I want to be precision based medicine, right? What is precision based medicine? Precision based medicine is now I need to know the genomics of the patients, right? I want to kind of swap them. I want to know which receptors works on them and which doesn't. Because all these studies are done. Do you think the studies that drug companies are doing is diverse studies? Do you think they have 20% Caucasian, 20% African American, 20% Indian American, other Asian Americans? No. It's the healthy patients, mostly Caucasian patients. The genetics are so different for an Asian American compared to an African American, compared to any other, right? So that's where we have to see. So a lot of time, why in SSRIs and psych medication, oh, medication A doesn't work, so we kind of deprescribe, start another one, because it doesn't work for your gene. So I started stratifying, and the answers that I started finding was amazing, makes sense. I'm sorry that I was judging Mr. Smith for asking for more opioids. Actually, you need opioids. Mr. Jones doesn't need it. I'll work with him later. But I know why you are always in pain. Even I went up on your medication because his metabolism, his genes were different. And now Mr. Jones, who doesn't need it, but he was taking that medication, and that's why he was sleeping all day in the day center. So those are the things I started finding out. Plavix, I did prescribe out of 50 patients who was in Plavix. I was able to prescribe 10 patients of Plavix because they don't have the gene that even Plavix works on them. Right? So those are the things kind of you start. So precision-based medicine, that's where I am right now. That I'm over with preference, trial, error. This is where I am in precision-based medicine. But what happened? We always say you have to take the right medication. If you take the right medication at the wrong time, that's not helpful either. Right? So what genomic testing started giving me an answer for these patients was, think about a grocery store parking lot. If it's one parking spot available, and that big, here, the little trucks, right? Like two F-250 gets into their parking lot, my Kia won't even get a chance to park. That's what happens with medicine. That a medication that can attach to the receptor faster is actually taking that spot. So what happens? You take your two medications, only one is working. The another one is just looking or driving in that parking lot until they find an open spot to attach to a receptor or find an open parking spot that they can park. And that's what happens in medicine. So what? You are getting the side effect of the medication, but you are not getting the benefit of the medication. So a lot of time, what my pharmacist will come and tell me, Dr. P, these two interacts at the same time. Do this medication A in the morning and B in the evening. And you see better results, right? This is where I want to, right? Predictive-based medicine. If technology is coming, you always are listening to this fancy buzzword, AI, right? Like my kid is like, Dad, I'm like an AI. I'm like, why? It's like, I wake up at 6:30, get ready at 7, eat my breakfast at 7:50, then go to school. I'm like, son, that's routine. That's not AI. But the point is, this is where embrace the technology. I always say that a lot of people ask me about technology and my thought. I'm like, technology is something, just keep an open mind. You don't have to accept whatever they are telling you that this works. Keep an open mind. Listen to what's new things are coming into the market, because we don't want to be behind either on the curve. And this is where I want to be one day with predictive-based medicine, that all my bags that goes into puts the medication in the computer, look at the compliance things, look at, the age, the metabolism, the same genomic. If I have genomic test on now 200,000 Caucasian and 100,000 African Americans and 50,000 Indian Americans, and so I'm like, this is when I have that kind of days beta, then I can start predicting how genes are working and what kind of medication I should prefer in certain types of patients. So I want you to think out of this four, which one you want to be. You could be wherever in the journey right now. But these are the things you want to walk out with, right? Coming back to the story. You remember Mr. 73-year-old patient, daughter crying? Fast forwarding it 5 months later. The patient was in the room, very well dressed, talking, actually answering to my questions. Daughter got up and gave me a hug. She didn't let the hug go for 3 minutes, was just crying and said, "Thank you, Dr. Patel. Because of you, my dad today does not need to go to a nursing home. I can take care of him at home. Pace is giving me that extra services with the aides, which is good enough. I don't feel burnout, and I can take care of him. Think about the dad. He was quiet, but he was happy. He's like, Dr. Patel, I'm so happy that I'm not a burden to my daughter. And at least I'm helping her load the dishwasher. It's a little things, right? Little things that matter, right? So here, sometimes you live in Seattle, why you don't walk with, why you go out without an umbrella, right? You have to take, it's as simple taking proactive approach. Medication thing, polypharmacy was, I just told you, 1/3 of the story, what happened there, right? But there's other proactive things in healthcare we need to do. And I was reading it, SMA's mission, right? Improving the quality of patients' care through multidisciplinary internal education. This is what, whatever 3 things you learn, I want you to implement that next week in your practice. And that's what will matter to me. That's what would matter for organizations like SMA that who wants to do more, get involved. Students, residents, you need to be involved in committees in your hospitals. That's how you start taking your leadership role. I was denied from 4 committees. So you know which committee I was, because nobody wanted it, was C. diff committee. Nobody wanted C. diff committee, so I became the chair of the C. diff committee in the hospital. And we started calling ourselves a cool name. We are Poop Troop. I was the captain because I was the chair of the committee. But Poop Troop becomes so cool that nobody was paying attention in the hospital to C. diff. We reduced C. diff infection in the hospitals by 50%. So it doesn't matter where you start, just start, right? Get involved in leadership. Physician needs to have a role, seat on the table. We can't always make now, I don't have time, I don't have this, I have to see so many patients, to stop complaining, right? Take the seat on the table. We need to get in, and it starts from residents and students. So if you're in the room, this is something that I would like you to do starting next week. And don't wait, there's no time to wait. Okay, prevention. So one of the things when I was driving, I'm like, I need to use my players right? So polypharmacy was one. But did you know you have a whole team of healthcare here? I love soccer. I'm happy Messi is here now playing soccer in US. But if you think about soccer, when you think about proactive approach, that's your attack. You want to score goals. That's your proactive approach, right? How many times you use or taught physical therapists as your forward and social worker as your forward? They are my Messi and Ronaldo. And the reason I say that is, how many have written an order, send the patient to rehab in this room? Most of them, right? Rehab. Reactive. How many of you have thought about prehab, proactive? When I say prehab, I'm talking about why patients are laying in the bed for pneumonia for 4 days. One day of sitting in bed for geriatric patients, we talk about is 2 to 3 days of rehab or muscle loss. Your pneumonia patient for 5 days of length of stay in the hospital, you're looking at 10 to 15 days of rehab. I want you to think about prehab. Why can't they walk for 10 minutes in the hospital? Muscles is something you use it or lose it. So you want to be in that category of prehab. So ask your nurses if you're rounding in the hospital, why Mr. Smith or Miss Jones didn't walk yesterday? I don't know. Attached with the IV cat, remove them if they don't need it. Make them walk for 10 minutes. Trust me, you are saving a lot of days from SARS. That's what I do at patient. I send my own aide to the hospital so they can make the patient walk, right? So that's what social worker, I never got burnout with the sickest patient. Never. Sickest patient never burns me out. What burns me out is the social needs. Patients cannot afford the medication, do not have transportation. That burns me out. And that's where social worker and physical therapy are my top of my line. They are my Messi and Ronaldo for me when I play my game of soccer or game of geriatric in my mind. That's how I spot them. And you know what? If you have them on your team, make them realize that they are your Messi and Ronaldo. They will even score more goals for you. That's what matters in proactive, right? Then my whole team, mental health team, my transportation team, those are the team members. Those 8, they're not just the 8. The transportation driver is not just a transportation driver for me. They are actually the first line in defense to prevent the ER visit for me. You know how? Because all my transportation drivers are trained that if Miss Smith is walking with her walker and usually take us 30 seconds from her door to get on the bus, but if Miss Smith is taking longer, she feels more looked out of breath than usual, or she's in pain, you let me know. We see them same day. Because you know what? She might be having pain. She might be having COPD exacerbation. Start treating them. Hit them with steroids the same day. Or aide knows that if she can't put Miss Smith's shoes on, how she normally puts it on, she'll come and tell me, you know why? Because the ankles might be swollen. If I don't do anything in 48 hours, patient will have a CHF exacerbation. So when my transportation driver and aide, they love it, and they'll write the name too. Miss Smith, ankles swollen, they'll put their name next to it because I was the one who discovered it. So empowering your aides are not just somebody who works for $15 an hour for you. When you make them feel empowered, if the closest McDonald's is paying 17, they're not leaving you. They're not, because they feel that this is the community that actually I'm helping the community where I actually live. Right? So those are the players that you have to kind of leave. Then you have the providers, nurses, and your medical director, primary care job responsibility is to block the goal. That's where more the ball stays on the offense, more you are playing defense, which is reactive medicine. You need to normally see your doctor every year, 2 times a year, not every month. If you're seeing every patient that often, that means you're playing so much of reactive medicine there. So that's one. 2, never, ever, ever, ever forget the caregiver in this thing. If you are caring for the senior, you need to care for their caregiver as much as you care for your patient. I've never seen a healthy patient if the caregiver is not healthy. Caregiver needs to be more mentally healthy to care for their loved one. So always think about the caregivers. And if you have, especially in corporate companies, when I'm giving a talk at a big corporate company, I always say that your best player, your best employee could be a caregiver. So make sure that if they're going through that caregiving time, support them for that 1 year when they're a caregiver, because you know what? For the rest of their life, they will go above and beyond for you. Okay, think outside the box. Embrace technology in prevention. So this is where all this fancy thing started. This is what I was doing in 2016, that I can't go to all houses. So I put those glasses, which is HoloLens, that my nurses used to wear and go into patients' home. And I will tell them, so whatever she's looking from those glasses, I see it on the computer, right? So I tell her, look left. I'm like, oh, that cord, do you see that oxygen cord? That's the reason Miss Smith is falling, right? So you get to see what goes on in the house, right? But these are the examples I'm giving you that how sky is the limit on being proactive in practicing medicine. Talked about postmortem. How many of you in this room wants to die in the hospital? Nobody, right? Why our patients are dying in the hospital? Because we never asked them what they wanted. When I started, that 1P was postmortem. Only 19% of the patient had postmortem. We changed that within 6 months. 100% of the patient had goals of care form. Miss Smith, what matters to you first? What happened there? 2014 and 15, Before my time, 64% of the patients that died, they all died in the hospital. After the postpartum I had, 34, 22, 25% of the patient dies in the hospital. This is an example of proactive, not reactive, right? These are the things that you can do just asking and talking to the patient what matters. Coming back, do you remember my CEO wanted to shut down that PACE program? Okay, let's come back to them. The hospital admissions rate was 11%, went down to less than 5%. ER admission from 10% to less than 4%. Readmissions from 22% to less than 12%. The cost of patient hospital cost of $1,100 PMPM, which is per member per month, right? That went down to $539. A program that was losing $3 million started making $2 million. So what they can do now is take care of more patients, invest in their employees' education. Okay, and that CEO decided not to close the program. We actually expanded 2 more centers in South Jersey. From serving 150 patients, now they're serving 500 patients there. And he took me out for dinner in Philadelphia. And this is very important when I say let it go for providers, okay? We talked about patients, we talked about administration, work, and everything. Talk about yourself too. Your mental health is more important than anybody else. Your family matters more than anybody else. At end of life, when I've taken care of hundreds and thousands of patients, nobody told me I wish I made more money. Everybody told me was, I wish I spent more time with my family. I wish I had a better relationship with my family. So things of past or any baggages you have in your life, just let it go. Move forward, stay mentally healthy, enjoy your family, enjoy your work. That's how we'll get the best out of primary care physicians, other specialist physicians. They need us. Community needs us. We are not enough of us. And that's what I want you to think about. And with that, thank you very much for listening to me. I'll open up for questions. This one is the LinkedIn QR code that you can connect to me anytime. You have my book, and I put in a sticker in the book, which is the QR code. So I have my email in that, so you can contact me anytime via email. And the proceeds from all the books goes to senior charities like Social Determinants of Health, which is food insecurity, senior loneliness, bucket list for seniors, which is, we work on, which is one of my favorites to do for all the proceeds. So please, if you like the book, rate and review the book on Amazon, and the QR code will take you there. With that, thank you very much for listening to me.
We have about 5 minutes.
We have 10 minutes for questions. Yeah, I went 5 minutes over, but we still have 10 minutes for questions. So if anybody have questions, I'll be happy to take.
Questions? Hey. Question.
Hey,
I love it.
My question was the medication polypharmacy project that you put into process. I know it sounds really simple, but I'm always getting asked by patients, okay, what do I do with this medication? Just throw it away. A lot of our pharmacies, I'm in New Orleans, won't take cold medications. And then I'm trying to figure out how to, I know it sounds very simple. So I have bottles of medicine. Sometimes I scratch the name off and just throw them away.
So yeah, so a lot of time, most of your closed health system always have a medication dispensing thing. So if you have whatever hospital, so hospital has it, the 911 team, the medical respondents, they have it. And you can even there are companies that actually does it, that you can put it in the box. You know how we have those blue recycle bins? They have boxes for medication that one of the companies will come and split it.
Okay, so the patient should be able to bring it to us.
They should bring it, we should discard, because they flush it in toilets. Right? Or just put it in regular garbage cans. So in that way, it's better that we will dispose at a safer place. Gotcha. Any other questions?
You have one back here. Hey, I was just wondering what technology you use. You were talking about that, and also what genomics system you were using, or what company you were using.
So, with the technology, so we have a proprietary software, but we call it MedWise. But it's more like I will even tell you to start what technology your EHR has, right? Because a lot of EHR has it. And do they have that's one-on-one or multi-drug? If it's multi-drug, that's a better one, right? We have MedWise, which is one of the great software that integrates too with a lot of EHRs as well. When it comes to genomic testing, to be honest, they are mostly standardized genomic testing that I don't prefer one over another. They all are good, but I would use somebody's service. So as a primary care doctor, a lot of times you don't have the time to interpret all this, and that's not even our specialty. So the genomic test I will prefer, who they have a pharmacist, they look at the med list, they look at everything, and then they give me the report. So I'll pay for that extra service if they have to pay $50 extra for the genomic test, but you give me that services that I can actually